Дима, я могу начинать или вы подойдете? Да? Я могу начинать просто разговаривать? Да. Okay. Okay. I think. Good afternoon, students. I think you can hear me well and see the slides, and myself also. Today we will speak about gynecological topic devoted to, as mentioned on the slide, on the screen, to abnormalities of development of genital organs and abnormalities of the position of genitals. I have nothing to disclose about this topic about myself, but we're gonna start. Well, congenital malformations of the female genital organs are defined as deviation from normal anatomy resulting from embryological abnormal development, mainly of the Mullerian and paramesonephric Wolffian ducts, if you remember histology and embryology. They represent a rather common benign condition with a prevalence up to 7%. Until the 8th week of gestation, the human fetus is indifferentiated sexually and contains both male and female genital ducts. Male, we say Wolffian bodies, and female Mullerian bodies, tract. So, and you can see on the slide, on the screen, this is undifferentiated fetus, and since the 8th, 9 weeks of gestation, if the fetus is female, the degeneration of the Wolffian tract starts, and genital organs permitted to female or female type, and vice versa. In the male fetuses, Wolffian tract is differentiated, and Mullerian genital tract are degenerated. I hope that you hear me well. I'm not sure, but I see that many of you are present now. Well, Wolffian structures in the male fetus differentiate into vas deferens, epididymis, which is located close to the testis, and seminal vesicles, shown on the screen. And this is the Wolffian duct. It's cross section of the human fetus. See here the Wolffian duct. And this is neural tube, and this is endoderm, and okay, this is the part of the Wolffian duct. And if we see in female fetus, we see that ovary, and very close between the close to the ovary, between the ovary and the oviduct, the fallopian tube, you see the remnants, mesonephric remnants, which represent remnants of the Wolffian bodies. Wolffian or mesonephric duct can be seen, the remnants of it, or pathology of the remnants in the female fetus with the absence of testosterone secretion. Obviously, in the female fetus, the Wolffian duct regresses, and those remnants, those inclusions, may be seen as a pathological conditions like Gardner cyst, you see here on the picture, on the photograph, just close to the cervix, and here on the lower photograph, you can see the remnant of the Gardner cyst. And the picture in above is a para-ovarian cyst. It's formed from those remnants, those inclusions of the Wolffian duct. So we often cope with such pathology in gynecological practice. Mullerian or paramesonephric ducts. Paramesonephric or Mullerian. Periducts of the embryo or fetus that run down the lateral sides of the urogenital ridge and terminate at the sinus tubercle in the primitive urogenital sinus. In the female, without the absence of anti-Mullerian hormone, AMH, anti-Mullerian hormone, they will develop to form the fallopian tubes, uterine cervix, and upper part of the vagina. So please remember that in a female, without the obvious influence of anti-Mullerian hormone, Mullerian ducts start to develop fallopian tubes, not ovaries, fallopian tubes, uterus, uterine cervix, and upper part of the vagina. In the absence of testosterone in the female and dehydrocyte testosterone, the genital tubercle develops into the clitoris, and the labia-scrotal folds do not fuse, leaving labia minora and labia majora. Okay, so again, without testosterone or other androgens in the female fetus, the genital tubercle develops into the clitoris, which correspond to penis in the male fetuses. And the labia-scrotal folds of the embryo, they form labia minora and labia majora. This is a pictogram. You can see that Mullerian ducts, they fuse, and cloaca then forms a urogenital sinus and sinovaginal bulb, and then those Mullerian ducts, they fuse completely and form uterus and the fallopian tubes. And after the delivery of the newborn, you can see that uterus is completely formated with fallopian tubes. But ovaries are not formated. They not come from Mullerian tract. They come from paramesonephric tract. Wolffian duct, sorry. A reliable classification system is extremely useful for the management of genital abnormalities. Unfortunately, we don't have uniform systems for classification. Many professional societies and bodies like American Society for Reproductive Medicine, they have their own system in North America, and European countries, they have a SHRE classification system for female genital anomalies. So we don't have so far uniform system, but still, but we need to follow any of this system, and you can do it in your daily practice if you are a gynecologist. So European classification system, which is published not recently, quite new in 2013, anatomy is the basis for the systematic categorization of the anomalies. Deviation of uterine anatomy deriving from the same embryological origin are the basis for the design of the main classes. Third, anatomical variations of the main classes expressing different degrees of uterine deformity and being clinically significant are the basis for the design of the main subclasses. Cervical and vaginal anomalies are classified in independent subclasses. You can see here the picture from the Schreib journal, Human Reproduction, and you can see here the normal picture of the uterus and abnormal forms of the cavity of the uterus, T-shaped uterus you see here, and you can see the arcuate uterus and uterine septa and rudimentary horns and unicorn uteri and bicornual uterus as well. So this is quite very simple, could be very simple for understanding. So when you see the patient in your office or in a department, gynecological department, you need to examine those patients and to follow your routine. So some vaginal and some cervical malformations can be diagnosed objectively by inspection, like it's shown on the upper photograph. You just open the labia majora and minora and you see the septum in the vagina. So it's not necessary to do specific tests. Palpation through the vagina or rectal examination cannot provide definite information for the uterine cavity and uterine walls, so we don't think it's very useful in the up-to-date practice. So they're very subjective, and we need to do other tests, and we will speak about it later on. It is always the starting point, an essential part of any woman clinical evaluation. So careful inspection of the vulva, vagina, vaginal walls with speculum to establish the presence of one or more cervical bodies, with two cervical openings, like it's shown on the photograph down. You see letter A depicts their right cervix, and letter B is shown on the left one, a little bit upper. It's oblique, in oblique position. So two cervices, two portion of the uterus. With just simple inspection, you can see and notice imperforate hymen, which may result in formation of hematocolpos, which from ancient Greek language we can translate like collection of the blood inside the vagina, hematocolpos. And usually we don't pay much attention until the puberty of the female patient, when menstruation obviously failed to appear, so no periods, no menstruation, and patient maybe have feelings of pain, periodic pain, attacks of pain, or lower abdominal pain with no outflow of the menstruation. With recurrent menstrual cycles, the blood collects in the vagina. It's like a cork in a bottle. It stops the fluid, menstruation, the blood outflow from the vagina. So blood collects in the vagina behind the hymen membrane and forms collection of the blood. So hematocolpos. It is the complication of the imperforate hymen. If it is noticed in time, not much problem will come to this patient. But if this patient come quite late to your the department, to the doctor, this hematocolpos also may result in hematometra and hematosalpinx, because this is the tract, the patency of the tract usually leads to formation of such profound complications. So anyway, imperforate hymen usually presents as primary amenorrhea in adolescence. Also, patient may complain on frequent urination, bloating, painful bloating, usually cyclically, not every day, but sometimes it's exaggerates. The most common scenario is that in which the young woman presents with increasingly severe intermittent abdominal and pelvic pain due to large collection of the blood, menstruation blood, with formation not only hematocolpus but also hematometra and hematosalpinx, like it is shown on this picture. And I hope you can see it up there. Treatment of imperforate hymen usually is very simple. It's surgical one. Of course, we can prescribe non-steroid anti-inflammatory drugs, which are quite symptomatic to relieve the pain, painkillers. Sometimes narcotic analgesics are required, but the definite treatment usually is a surgical one. We call this procedure a hymenotomy. Hymenotomy, which you can translate like the incision of the hymen. Usually it is done by X-shape incision, and the blood start to outflow from the vagina immediately during this. Sorry. The next problem is atresia of the vagina. Atresia of the vagina, so congenital anomalies, maybe they're usually very complex, quite rare when we have some isolated problem. Vagina may be absent in whole or partially, for example, in the upper, middle, or lower part. In these cases, the ovaries are present and function normally. Rarely the uterus and tubes may be normal and give rise to hematometra. If vagina is absent in whole, the full length, we call it aplasia of the vagina. One of the famous, if I can say so, syndrome, we call it Mayer-Rokitansky-Kuster-Hauser, a very long name of the syndrome, named after four gynecologists. So this is consists of vaginal aplasia with other Mullerian duct abnormalities. This condition causes the vagina uterus to be underdeveloped, so not developed completely. Usually those patients, they have these patients come to the office with the primary amenorrhea. If patient is married, she may complain on infertility also. Usually those patients, they have normal chromosomic karyotype, and though their ovaries function well. You can see on this photograph and the picture that this is the picture cross-section sagittal view of the female pelvis, and only the remnants of the fallopian tube, and you see normal ovaries over here, normal bladder and rectum, and no uterus here. And the same photograph, but it is done laparoscopically, you can see no uterus, only remnants of their rudimentary remnants of the uterine body, and the tube, left ovarian tube and left ovary is seen, and right ovary is seen on the pelvic wall side. And this is the pouch of Douglas. So no uterus is developed, no vagina also usually. So primary amenorrhea with normal ovarian function. And this is we call Rokitansky-Kuster-Hauser syndrome. Treatment of this syndrome, we actually cannot treat it completely. We not do transplantation of the uterus, although you must be familiar that in some countries, like in Sweden, in the Turkey, in Canada, different centers, they work with transplantation of the uterus for patients specifically for Myers-Rokitansky syndrome, but it's not it only experimental, I can say. First, we need to restore sexual activity for such patients because they don't have a vagina if they want to be sexually active. Now, for the intercourse with male partner, we need to create a neovagina. This is a surgical procedure, the creation of the vagina, reconstruction of the new vagina. Sometimes this very small uterus is found in Rokitansky patients. In this case, surgery usually may give good effect and create the tract between the uterus, the cervix, and the vagina and vulva. In cases of congenital atresia, surgery for artificial vagina should be delayed until the sexual activity of such patients. Regarding pregnancy or infertility, it is possible to get pregnancy only with ART, assisted reproductive technology like IVF, but in the embryo transfer, they recommended for surrogate mother. Some patients may have ovarian dysgenesis. Like it's shown on the photograph, you can see absence of the ovary on the right side of the pelvic wall. If you can see the left ovary, but no right ovary. Sometimes we see complete ovarian dysgenesis in patients with some chromosomic abnormalities like Turner syndrome. They may have streak gonads, streak of ovaries, a small band of tissue resembling the ovary, but it's not ovary itself, of course. And but anatomically female patients phenotype, when the phenotype is female, they also may have Swyer syndrome pattern, for example 46XY karyotype, which indicates that from the biology side it's a male patient, but phenotypically it is female patient, and those gonads are usually testes and not ovaries, and they only usually partially descend and usually be found in the pelvis or even in inguinal canal. Mullerian abnormalities, they most commonly come from incomplete fusion of the Mullerian ducts from right or left ducts, and double uterus or uterus didelphus occurs when the inferior part of the Mullerian ducts do not fuse. This condition may be associated with double or single vagina. Usually it's a single vagina with the septum inside the vagina, longitudinal septum. Another story is a bicornuate uterus, which result when the lack of fusion is limited to the superior part of the uterine body. So if you see on the picture, this is double uterus, so completely two different uteri, two different services, very adjacent one to another, and this is we call uterus didelphus. In uterus bicornis, sometimes it is two cervices, but sometimes even one cervix. You see here, this is the uterus didelphus, two uteri inside the pelvis, and this is uterine bicornis. It's a heart-shaped uterus, one left corn and right one. You can see with one fallopian tube from each one. Yeah, so this is uterus delphus. This is bicornal uterus. If one of the ducts is poorly developed or degenerated during the fetus formation, fusion with the other ducts, it's not occurred. The result is a bicornal uterus with rudimentary horn, which maybe communicate with uterine cavity or maybe not communicated with uterine cavity. So it's maldevelopment of the second corn, second duct, and this is uterus unicornis, and unicollis, one cervix, and this is rudimentary horn. Septated uterus is seen quite often in patients with anomalies. Usually represents with some wall inside the uterine cavity. It divides the uterine cavity, which is usually in a triangular shape. It's usually divides on two parts, two compartments. The septum usually has fibrous tissues inside, maybe partial septum, so we call it subseptate uterus, and maybe complete. In this case, it usually goes down to the cervix completely. If you enter with a hysteroscope inside the uterine cavity, you see two complete compartments. Uterine septum rarely extends to the vagina. It's different pathology. It's septum in the vagina. Usually we'll speak about the diagnostics for uterine anomalies, but here I showed you some photographs with ultrasound, hysterocontrast sonography, and this is hysteroscopic view of the two parts of the uterine cavity, and the septum is in the middle. And this is radiographic or X-ray examination. You can see also two parts of the uterine cavity, which is divided by triangular shaped septum. The treatment of the uterine septa is a surgical one. You cannot treat it with pills, with drugs. Usually we do it hysteroscopically. Resection, electrosurgery, intrauterine electrosurgery, and for post-operative management, we need to prescribe estrogens for prevention of the adhesion formation after the resection of the septum. IUD insertion maybe for a couple of months after the surgery may be useful to prevent adhesion formation, or anti-adhesive barriers specific glue which contains cellulose, and you can inject after the surgery into the uterine cavity, and it prevents the formation of the synechiae adhesions inside the uterine cavity. Usually patients with Müller anomalies, they come to the office with symptoms, with signs, depends on the menstrual drainage or abilities. They also come with the fertility problems, and sometimes they come as obstetric patients with some complaints of their pregnancy continuation. Like threatened abortion, for example, or miscarriages. In most cases, the duplication of fusions of the uterus, they may have no symptoms, obviously, and diagnosis may be accidental in course of manual examination or during even the cesarean section, during the laparotomy. Pain or mass formation similar to endometriosis that gets worse during periods. If untreated, blood collects into the uterus and may become infected, and pus can be formated. A uterine anomaly may also be associated with dyspareunia, painful intercourse, and different reproductive problems like I mentioned before, infertility or inability to carry the pregnancy. So what can we do for the diagnostics of Müllerian anomalies and anomalies of genital organs? As I mentioned before, for some anomalies like imperforate hymen or vaginal septum, you can do just inspection, examination in the office, or and it's not usually it's enough. But as I mentioned before, again, anomalies usually are a complex one. You easily can see patients with Müllerian anomalies and some problems with kidneys, other organs problems, so you need to do some additional tests like ultrasound. Ultrasonography is simple. It's available, affordable one in almost every country. You can easily do ultrasound diagnostics. It could provide reliable information, objective information, and you can see the contours of the uterus, the shape of the uterus. It provides information for other pathology, like, for example, endometriotic cysts, other tumor formation in the ovaries, hydrosalpinges or hematosalpinges, and so it's very useful in everyday practice. And you can see here two photographs of the double uterus or uterus didelphus to the right, and on the left you see bicornual uterus. So those two uteri are close but separated from each other. You can see it easily on ultrasound. But here you see only two endometria, and the whole uterus. These two horns, they close together to each other. So ultrasound is very simple, objective, affordable methods of diagnostics for those pathology like double uterus or bicornual uterus. Also, we can do ultrasound with some contrast injection. We inject into the uterine cavity, into the cervical canal, fluid which outlines the uterine cavity. We call this procedure hysterosalpingo contrast sonography. It also can be used for tubal patency test, but if you suspect some anomalies, it's maybe very, very useful. And for example, you see here the method of high-CoZ echo contrast sonography. You inject the contrast fluid, which usually contains small bubbles inside, and you inject it, and you can see the passage through the fallopian tubes if you need to check for infertility reasons in specific patients. And also you can see the uterine cavity. If you see two cavities filled with fluid, you can say it's bicornual one, or maybe it's uterus didelphus, depends on the signs, ultrasound signs. Very popular nowadays, 3D ultrasound. It's not so widely available like 2D ultrasound, and it needs experienced sonographers, but it is maybe useful in the third level, tertiary level of hospitals. You see here bicornuate uterus on both of those photographs for definite diagnosis. These photographs also correlate with pictograms, X-ray pictograms, as I mentioned before. You see here, for example, normal uterine and normal 3D sonography, T-shaped uterus is here, and uterine septum is inside the uterine cavity, and it is a very good looking photograph and very comprehensive one. X-ray is not that popular like it was maybe even 10, 20 years ago, but still it's very useful in some complicated cases. It provides reliable information for the anatomy of the uterine cavity. It's easy to reproduce. You can send the slide of the X-ray metrosalpingograph to another colleague to get consultation. So it requires X-ray machine, which of course you can find in the hospital. So the photograph of the X-ray photograph of the bicornuate uterus is to the right, to the left, and this is to the right, unicornuate uterus with some fallopian tube, with left fallopian tube. And this is the bicornuate one. So very easy to see, very easy to understand what's to do with such pathology, what is the pathology. MRI, magnetic resonance imaging, non-invasive and non-radiative one. It has of course some disadvantages. It's very expensive. It's not available in every hospital. Maybe not every hospital has experienced radiologists who can explain the results of the MRI, but still it's very reliable and for detecting of the abnormalities of the genital organs. And some more slides. You can see bicornuate uterus with two cervixes, bicornuate and formation collection of the hematosalpinx. Hematocolpus. Sorry, this is hematocolpus to the right side. Endoscopy. It's since 1970s or 1980s, endoscopy started to be a very useful and unchangeable tool for diagnostics and for both treatment options. It provides information about anatomy of the vagina if you do vaginoscopic approach, the cervix, uterine cavity, also tubal ostia, the contour of the shape of the outer shape of the uterus, and some information about peritoneal structures, because you can do direct visualization of the cervical canal, endometrial cavity, and this is considered to be a gold standard for the diagnosis and differential diagnosis. Of course, it is invasive because, for example, laparoscopy is done under general anesthesia. It requires incision of the small incisions, but it requires incisions of the abdomen. Hysteroscopy is semi-invasive because you do it from natural orifices. And the invasiveness of laparoscopic approach makes it not accessible as a first line of diagnostics, not the first line of screening. So we need to do first less invasive procedures and diagnostic tests, and only if we have some doubts or not reliable information, you can recommend laparoscopy, for example, for such patients to get the diagnosis. You see the photograph of the right side unicornuate uterus. This is laparoscopic view. You can see the remnant of the uterine body, of the left uterine body. This is the ligament. This is the ligament, and this is the ligament, and this is the fallopian tube, right fallopian tube. This is the ovary, and this is the ovary on the left side. So this right monocornuate or unicornuate uterus. Another pictures you see here bicornuate uterus, and this is the hysteroscopic view of the uterine septa, and attempt to destroy this septa with the laser or bipolar or monopolar electrode. Look at the laparoscopy footage. See again, this is the rudimentary uterine left horn, and the right horn with some fibroids. This is the left ovary, left tube, fallopian tube is normal, left ovary is good, and the left rudimentary horn of the uterine wall. See here, well, and this is the right right horn with some fibroids, small and big one. Many cases of anomalies call for surgical corrections. That's why we need the systematic approach, the classification of anomalies, because different anomalies requires different surgical approach. Metroplasty is most often used to reshape the uterus. However, surgery is not indicated in every case and cannot be performed on the unicornuate uterus, as there is no way to surgically enlarge the uterus if it is unicornuate uterus. In case of bicornuate uterus, you can do metroplasty to join together two horns, but mainly this Strassman procedure, surgery, operation by Strassman, is not done in many countries globally. Surgical cerclage may be performed in some cases to prevent the cervix from dilating prematurely, in case of pregnancy, to increase the fetal delivery survival rate. Refinements in surgical techniques, different procedures for vaginal aplasia like Vecchetti or Makindo procedure have enabled many women with Mullerian duct anomalies to have normal sexual intercourse. Other surgical advances have resulted to improved fertility and obstetrics outcomes. Developments in assisted reproductive technologies allows some patients with Mullerian duct anomalies to conceive and deliver healthy babies, although with the help of surrogate mothers in some specific anomalies, like for example Rokitansky-Kuster-Hauser syndrome. Genital organs anomalies are a morphologically diverse group of development disorders that involve internal female reproductive tract. Accurate, definite diagnosis is very important for planning treatment and management for a specific patient. Surgical approach for correction of Mullerian duct anomalies is specific to the type of malformation and may vary in the different groups. For most surgical procedures, the critical test of the procedure is the patient's post-operative ability to have healthy sexual relations or achieve successful reproductive outcomes. And now we will go for the second topic of my lecture today, is abnormalities of the position of the genital organs. So if we speak about the position, normal, abnormal position of the uterus, we speak about the relation between uterine corpus, uterine body, and its cervix. Some inclinations of the uterus related to the symphysis or sacrum, location of the uterus in the small pelvis, elevation or the descent, or sometimes, very rarely, rotations of the uterus around the axis. So we describe position of the uterus by words versions and flexions, even in normal, in a healthy patients. So anteversion, it is corpus of the uterus is displayed forwards and the cervix backwards. Vice versa, retroversion, corpus of the uterus is displaced backwards to the spine and the cervix forwards to the symphysis. Dextra version, sinistra version, of course, correspondingly displaced to the right and to the left, depends on the side of the version. Hyper-anteflexion of the uterus can be pathological one, and this is the flexion, extreme flexion of the uterine body, and there is acute angle between the corpus of the and the cervix of the uterus. Otherwise, retroflexion of the uterus is a bending of the corpus of the uterus backwards, and acute angle between the corpus and the cervix, which is opened to the back. Some patients may have elevation or the descent of the uterus and internal genitalia. So sometimes uterus is elevated upward. The fundus of the uterus is situated higher than the plane of the pelvic inlet. The external os of the cervix is located higher than the spinal plane, ischial spine, I mean. This displacement may occur due to overfilling of the bladder in physiological situations and in rectum, and it is kind of normal. Pathological elevations of the uterus may occur as a result of hematoculpus due to imperforate hymen, as we described before, and hymenal atresia, sometimes due to tumors in the vagina and tumors in the rectum. Sometimes uterus is elevated because of their fluid collected inside the pelvis, for example, in cases of intraperitoneal hemorrhage. Because of adhesions joined together with other structures, like after the surgery, for example, after the C-section, sometimes adhesions are formated and uterus is elevated above the pelvic ring and adjacent to the abdominal wall. But usually we see not elevation, but we see descent or collapse of the uterus. The uterus, this descent may occur only if the cardinal ligament and uterosacral ligaments are stretched or maybe even torn after the delivery, especially after multiple deliveries. The perineal body does not support uterus. We need to remember that their introitus, the vulva, and vagina, they don't support the uterus. Uterus is supported by cardinal Muckendorf ligament and uterosacral ligaments, which are attached to their uterine cervix, so they support the uterus. The vagina usually descends first, but in few cases the uterus descends as a primarily, and only then vaginal walls fall down it. Degrees of the descents may be light, maybe heavy, for and uterus may be palpated even outside. So what are the reasons for the prolapse or descent? First, it is weakening of the pelvic support. During pregnancy, the structures are full of blood, hyperemic, and softened. And during labor, the fascia and muscles of the perineum, and not only perineum, and even those cardinal ligaments, they may be overstretched and may be torn. If pregnancies are repeated in a short intervals, the support will have little chance to recover, to get back. After the menopause, the pelvic structures starts to be atrophic and because low level of estrogens and prolapse frequently starts to appear. Signs of the pelvic organ prolapse or descent are usually sensation of discomfort in the perineal part of the body. Some patients represent with bladder symptoms, which include frequency of urination, incontinence, or vice versa, retention of the urine inside the bladder, and an inability to pee normally, completely. Some patients feel have sensation of foreign body in vagina. Of course, no foreign bodies really in the vagina, but sensation of foreign body in the vagina or between the legs. Many patients complain on pathological discharge from the cervix. If the uterus is prolapsed and the vagina is prolapsed, it may be ulcerated or infected, usually around the cervical os. And prolapse is often associated with bad quality of life and may contribute also to the bowel problems, not only urinary problems, but bowel problems and sexual dysfunction, obviously. And cosmetic problems, because patients want to be attractive even in this intimate part of the body. Traditional classification of the prolapse represents different names like urethra. It's a prolapse of the lower anterior vaginal wall, which with urethra only. Cystocele, it's a prolapse of the upper anterior wall, which involves the bladder also. Generally, there is also associated prolapse of the urethra, and hence the term sister urethroceles is more correct. Uterovaginal prolapse, the term is used to describe prolapse of the uterus, cervix, and upper vagina. Enterocele, it is a prolapse of the upper part of the vagina, which usually contains bowel loops. And usually it's the upper part of the vagina, not the lower part. It's the upper part of the vagina, which contains bowel loop. It's actually the herniation of the bowel loop through the vagina outside. And the last but not least, rectocele. It is a prolapse of the lower posterior wall of the vagina with rectal wall, which bulging forwards into the vagina. This is what was the traditional classification. Nowadays, we have pelvic organ prolapse quantification. The acronym is POPQ system, which provides characterization of woman's prolapse and allows to uniform recording method to be discussed between the clinicians. So it helps defining the features of the prolapse to create the system for reconstruction, for scientific research. Of course, it's very useful. And in the POPQ system, the hymen acts as a fixed point of reference, not cardinal ligaments or spinal ischial spines, but hymen. introitus is used for fixation point, well, not fixation, but as a termination line. So you can see it in the textbooks, and this is sagittal view of the normal, healthy, normal female patients, and these abbreviations like A, P, C, D, GH, PB, TVL stands for the names which anterior wall, posterior wall, correspondingly cervix or vaginal cuff in case of hysterectomy. D comes for Patrick Douglas, genital hiatus, and perineal body, and total vaginal length. As I mentioned before, hymen is a line for the evaluation of the prolapse in POPQ system measurements. So if we speak about stage 0, we say that we don't see any prolapse in a patient in stage 0. So you see here, so uterus located in a normal position, high above, and no descent is noted. Stage 1, the most distal portion of the prolapse is more than 1 centimeter above the level of the hymen. So if the most distal part is to this 1 centimeter above the hymen, we can say it is a stage 1 prolapse. But still, the genital organs, uterus, is located inside the vagina, above the hymen, or remnants of the hymen. Stage 2, the most distal portion of the prolapse is 1 centimeter or less proximal, the distal to hymenal plane. So this is stage 2. Stage 3, the most distal portion of the prolapse protrudes more than 1 centimeter below the hymen, so outside 1 centimeter and more, the most prominent part of the prolapse, but less than 2 centimeters. So between 1 to 2 centimeters outside of the hymen, it is stage 3 POPQ. And vaginal eversion or complete prolapse of the uterus is obviously stage 4, so which is more than 2 centimeters outside the outlet of the vagina. This is stage 4 POPQ. Great. Another picture you can see here. This is normal position of the pelvic organs: bladder, uterus, cervix, rectum, vagina, all is in place. If bladder starts to go down and the anterior wall correspondingly with it, we call it bladder prolapse or cystocele, and it depends on the level of the most prominent part of the prolapse. We can calculate the proper stage of the prolapse. You see here the rectal wall bulging in the uterine, into the vaginal canal, and this is the metrocele or uterine prolapse when uterus is still in the vagina. If it goes down, it can be a full prolapse. Actually, this is the full prolapse in the photograph of the patient with the full prolapse with some hemorrhoids also, and cystocele, large cystocele. And the picture by the artist, you can see here isolated cystocele and no much prolapse here of the uterus is seen. Treatment for the prolapse is a short surgical one. Only in weak patients, maybe too old patients for the surgery, for the anesthesia, or maybe some young patients who plan to give birth in the next few years, or for pregnant women, we can recommend palliative or conservative treatment like pessary treatment. Pregnancy in patients with descent on incomplete prolapse is possible and is often complicated due to failure of the blood supply to the uterus. Fetus, in most cases, cesarean section is considered for patients with pregnancy in prolapse or uterine descent. But of course, for, as I mentioned before, these pessaries, conservative treatment for the prolapse or temporarily before the patient waits for the surgery can be used. Different types commercially available, like donor types or membrane types, or this type of Hellhorn type of pessary can be inserted in the vagina to support the vagina in case of cardinal ligaments overstretched or torn. Of course, definite treatment are colporrhea, which namely means stitching of the vagina. So we excise excessive part of the vaginal epitheliums, vaginal mucosa and fascia, and create proper support of the vaginal tissues and bladder. If in case of cystocele, it's anterior repair. In case of rectocele, it is a posterior repair. So we about to finish my presentation, our lecture, and different types of genital organs displacement need different approach. Symptoms, for example, dyspareunia, types of the disorder, desire for fertility are of importance for any obstetrician gynecologist to choose proper treatment option. And reconstructive surgery, vaginal surgery, usually is one of the most significant for the treatment, for the definite treatment of the uterine and vaginal prolapse in patients with abnormalities of the location of the uterus and balls. So, dear students, thank you for your attention. I hope you can be able to discuss those topics in depth during the practical course, during the seminars with your teachers, with our teachers. But if you have some brief questions I can answer you, please type it over here. I'll be around 5 minutes to speak with you or to answer you. Anyway, thank you very much for your attention. Be healthy. Ну да, просто... Сейчас.
Число зрителей, активность.
Ну, да, где-то
Ну, ставьте на проходной или как-то. Вот, либо я, хорошо, либо как только уже подписывать, звоните, если это общественный транспорт, когда я туда заберу его, вернусь в институт, да. Ну что?
Я смотрю лекции других.
Я не смотрела других лекций.
Ну так пролистывал.
У меня сейчас еще 2 человека добавилось, то есть они входят и скачивают.
Ну, хорошо. Я оставляю. Можно, мне кажется, идти.
Ну, тоже думаю, что мы уже вычитали.
Да. Вот, Лариса Хлебовна, вот так. Так что мы теперь практически там, получается, ну, на ракетной были. Да?
У вас 87-я, да, была?
Была 87-я. Сейчас только мы чуть припозднились, чтобы какую-то конференцию настраивать.
Ну, я знаю, потому что я ему сказал сидеть, настраивать, а он...
Ну, это деканат звонит уже.
М.
Где?
Но при этом я успел на свои лекции сюда вернуться из главного корпуса, я вместе с ним был.
Ну, как бы.
Им расслабляться не надо, там не так много работы, чтобы... Творческая студия.